Yeah.
Sir,
Good
please
evening, all.
start. Yes, sir, please
Yeah.
start.
Good evening, all. On behalf of Maha IIP, I, Dr. Kundan Chopde, Executive Body Member, welcome you all for all IIP members for this second session of Protocols in Pediatric Practice, where we unveil protocols for excellence. This is one of the well appreciated and well sought program from Presidential Action Plan of Dr. Ram Gopal sir. And I am fortunate along with Dr. Matin to given this responsibility to conduct these protocols in pediatric practice. Protocols are system of fixed rules and formal behaviors that explains the correct conduct of procedures to be followed in certain situations. Protocols are needed to enable communication irrespective of differences. Clinical protocols are set in place to define the appropriate guidelines in the diagnosis, treatment, and care of patients. And the ultimate objective is to improve the overall quality of patient care. This is the ultimate objective we want. That is, overall quality of patient care should be improved. And after the Amras of Gudi Padwa and Shirkurma of Eid, level of sugar of all members will be on higher side. And today we are going to discuss protocols in the approach of child with diabetic ketoacidosis. And to present this topic, today's presenter is Dr. Mohammad Mainuddin Tambodi. And joining us as a distinguished expert is the esteemed Dr. Anand Bhutra sir, whose wealth of knowledge and experience will enrich our understanding of this critical topic. I will request Dr. Ram Gopal sir, President Maha IP, to give few words of wisdom. Ram Gopal sir.
Good evening, friends. Welcome to another episode of Protocol in Pediatrics. As the name itself suggests, we would be learning protocols. Now, today the topic is approach to a child with diabetic ketoacidosis. So today, Dr. Moin Tamboli will be giving all the protocols which are relevant to the case, and Dr. Anand Bhutra sir would be adding to whatever the current guidelines are there, and both of them will tell you exactly how to proceed in the case. And Dr. Kundan, as a moderator, we all know him, he will do his job. So once again to Dr. Kundan, we can start as early as possible.
Yes. Now I request our dynamic Secretary General, Dr. Amol Pawar, to say a few words.
I think his network has gone.
Yeah.
So we can directly, if he's there.
Yeah.
Amol?
Amol is not there, I think, sir.
नहीं sir, अमोल sir नहीं है.
Okay. We'll go to the introduction slide. Ma'am, can you show the Dr. Anand Bhutra's introduction slide? I will just introduce Dr. Anand Bhutra, who is Director, Pediatric Intensivist and Neonatologist at New Era Mother, Child and Care Hospital. And he has working as a secretary, chairman, executive body posts. And sir has authored 2 articles in few textbooks. He is national faculty at NRP and various modules, and his publications are there in Index Journal. And he held various posts as executive body member, secretary, and various distinguished posts he has held. Now I will like to introduce. I would like to say some few words to Dr. Anand Bhutra. Please speak few words.
Thank you, sir, for giving me opportunity to join this important session on protocols in pediatric diabetic ketoacidosis. This may not be a very common scenario, but this is one scenario where a protocolized treatment can save life, save complications, and a lot of mobile applications for managing pediatric diabetic ketoacidosis are now available. And this is all because there's a protocol which exists, and we should be learning a lot from Dr. Moin in coming few minutes.
Yeah. Now I like to introduce our today's presenter, Dr. Mohammad Mainuddin Tambodi. He is consultant pediatrician and intensivist. He is working as an assistant professor since last 5.5 years at VMGMC Medical College, Solapur. He has done MBBS from Government Medical College, Kolhapur, and MD Pediatrics from GMC Nagpur. And he has done PISU Fellowship, Indian Diploma Pediatric Critical Care Medicine from Distinguished Hospital, Rainbow Hospital, Children's Hospital, Delhi. He has 2 national publications to his name, and his field of interest is pediatric pulmonology and pediatric critical care. Over to you, Moin sir.
Thank you, sir. So at the outset, I thank Maha AP team for giving me permission. Am I audible, sir?
Yeah, audible.
For giving me this permission for presentation. So directly we'll begin with the topic.
Slides are visible, sir.
Yes, yes.
Yes, sir. Presentation is visible. Please
You can start, sir.
Yes,
go
sir.
ahead.
Ah. So diabetic ketoacidosis is the most severe acute complication in children with type 1 diabetes mellitus. So Diabetes Atlas 2022 report says that there are more than 2.5 lakh children and adolescents with type 1 diabetes mellitus in India, but exact prevalence in India is still unknown. So it is important because it is most common cause of death in children with type 1 diabetes mellitus and especially in children less than 5 years of age. Mm. Now, the incidence of decay is inversely proportional to population prevalence. So here we can see it is most common in new onset cases of type 1 diabetes mellitus, where there are 15 to 70% of cases with new onset type 1 diabetes mellitus. Just at the presentation, they present with decay. And if a patient is diagnosed with type 1 diabetes mellitus, there is 1 to 10% risk of recurrent decay. And 6% cases of youth onset type 2 diabetes mellitus, they can present in decay. Now, basic pathophysiology behind this decay is that there is absolute or relative insulin deficiency accompanied by the excessive increase in counter-regulatory hormones. Now, this absolute or relative insulin deficiency, it could be just in a case of new onset diabetes mellitus. They have low circulating insulin levels, or it could be omission of insulin therapy, which is going on in a child who is already on the insulin therapy or on insulin injections, or it could be failure of your insulin pump to deliver the insulin. So these are the common causes of insulin deficiency. Or there could be excessive counter-regulatory hormones, which are like glucagon, cortisol, growth hormones, which are released in response to stress, sepsis, and various infections or febrile illness. And another important cause is poor sick day management of type 1 diabetes mellitus oftenly lands up in decay. So basically what happens is that this absolute or relative insulin deficiency, it will increase the glucose production from the liver and kidney by gluconeogenesis and glycogenolysis. So this will cause hyperglycemia and hyperosmolarity. Simultaneously, it also increases lipolysis and it increases the ketogenesis, causing ketonemia and metabolic acidosis. Now, this hyperglycemia, when it exceeds the renal threshold of 180 milligram per deciliter, this along with your accompanying metabolic acidosis, it will cause loss of water and electrolytes along with the glycosuria. So this will cause dehydration, and this dehydration will further escalate the same cascade, causing more release of counter-regulatory hormones. These counter-regulatory hormones will increase again insulin resistant at the peripheral level. So this cascade will continue, and this again ketosis will cause severe ketosis will cause vomiting, and this vomiting will will further add to the dehydration, and poor tissue perfusion will lead to increase in anaerobic metabolism, causing increase in lactate levels, and these lactate levels will further add on to the acidosis. So this is the table which shows the average loss of fluid and electrolytes in a case of decay. Here we can see is that Along with water, electrolytes are lost. So important electrolytes which are lost and which need to be replenished are sodium, potassium, and chloride. So on an average, in a DK patient, there is 70 ml per kg loss of water, along with 6 millimoles per kg loss of sodium, 5 millimoles per kg loss of potassium, and 4 millimoles per kg loss of chloride. So the learning point is that water, along with fluid deficit, you have to collect the electrolytes. Without that, the child will land up in complications. Now, what is the typical clinical presentation of DK, which we usually encounter? The child presents with dehydration, typical acidotic breathing with rapid deep sighing breathing. The child, because of severe ketosis, the child has nausea, vomiting, and abdominal pain. And most often, the first year miss it as a case of acute abdomen. Severe acidosis, severe decay can have cerebral edema, which can cause progressive obtundation and loss of consciousness. Decay has to be suspected. If you don't suspect, you are not going to diagnose. You are not going to do blood sugars. You are not going to go for blood ketones or urine ketones. So the common differentials which mimic decay are pneumonia, acute gastroenteritis, sepsis with septic shock, acute abdomen, and severe UTI. So common clinical markers which can help in differentiation are that the child has tachypnea, but the breathing is not shallow, which we commonly get in lower respiratory tract infection. Whereas here you have a central deep sighing breathing. The child is dehydrated, but there is no history of any loose motions. And another important thing is that in diabetic ketoacidosis, despite severe dehydration, urine output is maintained because of preservation of your intravascular volume. And urine output is the last marker to go, and the patient lands up in the shock immediately. So dehydration with urine output continues. Usually BP is maintained till patient suddenly collapses. Now, what are the risk factors for the decay? As we have already discussed, in a newly diagnosed patient, younger the age, the more severe the presentation, delayed diagnosis, lower socioeconomic status, they seek to the healthcare. They have very less infrastructure to go to the healthcare. Countries with low prevalence of type 1 diabetes mellitus and poor health infrastructure. Now, in patients who are already diagnosed with type 1 diabetes mellitus, common factors are the insulin is omitted, especially sick day management. Sick day management is very crucial. The important part in the treatment of decay is not only just you treat fluid, electrolytes, you do ICU management, but prevention of decay is most important. Why the child landed up in decay? The child was already on insulin therapy. Because of sick day, the child is not accepting orally. The parents have stopped the doses. So sick day management is very important. Gastroenteritis with persistent vomiting, poor metabolic control, adolescent and peripubertal girls, challenging families, and failure of insulin pump therapy are other known risk factors. Now, this is a biochemical triad for the diagnosis of decay. Hyperglycemia, we already know blood glucose more than 200, ketonemia and ketonuria more than 2 plus, and venous pH less than 7.3 or bicarbonate less than 18. Previously, bicarb levels we used to take as less than 15. Now it is bicarb less than 18. Now let us see how do we grade or how do we do severity classification of decay. Decay is classified as mild, moderate, severe traditional classification. Both ISPAD and Milwaukee, they have same mild, moderate, severe. pH less than 7.1 is severe, 7.2 to 7.1 to 7.2 is moderate, 7.2 to 7.3 is mild. Severe cases will have bicarb less than 5. Moderate cases will have bicarb levels between 5 to 10. And mild cases will have bicarb between 10 to 18. Ketones will be positive in all of this, whether it is blood ketones or urine ketones. Ketones more than 2 plus in urine and more than 3 that we have already discussed. Another clinical marker which signifies severity class is sensorium. Altered sensorium, stupor, or comatose makes the child go into severe decay. So once you have diagnosed the child, now you have to decide what are the important points to remember during the assessment, what will be their immediate management steps, which investigations need to be ordered, and which lines, which tubes, what all you are going to secure for the child. So initial assessment, this is standard ABC pulse approach to maintain airway, breathing, circulation. You have to see the child is stable, make the child stable prior to do a complete primary assessment, secondary assessment, and tertiary assessment. Once you ensure airway, breathing, circulation, you obtain vital signs, you measure weight. Current weight should be used. Past weights are usually discouraged. You insert a peripheral IV line, you immediately obtain a blood sample, send preliminary investigation, and you start IV fluids according to the guidelines. So samples that we'll discuss later, what samples we are going to send. So initial assessment, obtain vital signs that we have discussed. Assessment of consciousness. Assessments of consciousness is very important because altered sensorium or your if the child is stuporous or comatose, that indicates the child is probably landing up in cerebral edema. In such children, always see that you have secured the airway, you keep the airway patent and maintainable. Put NG tubes so that they don't aspirate, decompress the stomach. As long as possible, avoid intubation. If the child is in circulatory impairment on shock, we will start with oxygen by non-rebreathing mask. And another important is continuous cardiac monitoring. These children are prone to have arrhythmias because of hypokalemia and hyperkalemia. So continuous cardiac monitoring is essential. Your T wave flattening will show you hypokalemia. Your tall T waves will show you hyperkalemia. Prolonged PR intervals, again, you get prolonged PR interval and QTC interval that you get in hypokalemia. So continuous cardiac monitoring, just seeing the rhythm of the child bedside is very important. Now, how do you assess the severity of dehydration? This is something which is emerging. So conventionally, we classify the child as severe dehydrated, moderate dehydrated based on your clinical findings. How is the CRT? How is the skin turgor? How are the peripheral pulses? How much is the BP? But recent studies have emerged which suggests that this clinical grading of dehydration is imprecise and it can actually overestimate sometimes. And these patients are most of the times they have their intravascular volume is preserved because of the osmotic draw. So just based clinical judgment, the degree of dehydration based on clinical parameters is imprecise. Yes, you can categorize shock if the child has prolonged CRT, abnormal skin turgor along with or without hypotension. But what ISPAD says, ISPAD 2022 says laboratory parameters are more precise for predicting severe dehydration than your clinical parameters. So they have given two laboratory parameters. One is pH less than 7.1 and high blood urea nitrogen more than 20. These parameters, when they are there, the child is going to have severe dehydration. Now, lines and tube. At the onset, when you receive the child in ER, you will secure two peripheral lines. One, to start fluid therapy. Second, for your insulin therapy. And simultaneously, we'll do sampling. Preferably, we avoid central lines and arterial lines. They are avoided unless the child has refractory shock or he has intractable hypokalemia where you need to give large amount of potassium. Then only you will put a central line. NG-tube, as we have already discussed, NG-tube are going to secure if the child has altered sensorium to avoid the risk of aspiration. Foley's is for bladder catheterization is avoided only if the child is unconscious and the child is small and very sick child, then only we are going to catheterize the child. Now, what investigations we will say? These are the first line investigation we will send from the ER: blood glucose, blood ketones. If you don't have facility for blood ketones, you will do urine ketones by the dipstick. Venous blood gas or arterial blood gas, whatever is available, is mandatory. Second line investigations important are serum electrolytes, sodium, potassium, phosphates, blood urea nitrogen, creatinine levels, complete blood count with differential blood count to rule out the source of infection if you are suspecting any, and HbA1c. This is particularly important in the cases of stress hyperglycemia, where you have children with hyperglycemia, you have sugars of 400, 500, but HbA1c is normal. So these are the common indices we are going to calculate when we have the reports. Corrected sodium. Now, diabetic ketoacidosis is a state where sugar is predominantly, blood glucose is predominantly in the extracellular fluid, and this it will draw water along with it. So this is going to cause dilutional hyponatremia. So usually the patients are found to have hyponatremia, but they don't have true hyponatremia. We need to correct the sodium, and this is the formula calculated by measure sodium plus 1.6 into glucose minus 100 divided by 100. Then another thing which we calculate is anion gap. Diabetic ketoacidosis is wide anion gap metabolic acidosis. Anion gap sodium, serum sodium minus chloride with bicarbonate levels, anion gap more than 20 suggests that the child has diabetic ketoacidosis. And osmolality is important, particularly when you are titrating the fluids, how much tonicity you should maintain. So you have to target the osmolality of 280 to 300 to prevent cerebral edema or your AKI, to avoid fluid transitions and osmotic shifts. So osmolality is calculated by 2 into sodium plus potassium plus glucose upon 18 plus blood urea nitrogen upon 2.8. Other ancillary investigations, depending on the scenario you are going to send, culture specimens of the blood, urine, throat swab. If there is evidence of any source of infection or you are suspecting sepsis, chest X-ray when you are suspecting pneumonia. And once the child is stabilized, then after endocrinology opinion, other endocrine screening like T4, TSH level and celiac screening you will do. Now this is important. What we should measure? Urine ketones or serum ketones? Ideally, point of care suggests that serum ketones have to be measured. So in the pathophysiology, the counter-regulatory hormone will cause lipolysis and increase in ketones production. And these ketones, there are two types of ketone bodies which are produced. One is beta-hydroxybutyrate, second is acetoacetate. So in the initial phase of the decay, beta-hydroxybutyrate is the predominant keto acid, and the ratio of beta-hydroxybutyrate to acetoacetic acid is 10:1. Now, as the child goes into the resolution phase, this ratio turns from 10:1 to 1:1. So urinary ketones, yes, they are they measure acetoacetate. The urine ketones test is based on nitroprusside principle, but the thing is that these serum ketone strips are more costly, and they need a specific meter that may or may not be available. So for monitoring purpose, urine ketones are poor marker. That is, despite resolution of your ketoacidosis, you might find ketones. So you can't just continue your insulin infusion just based on your urine ketones, because it is going to be there even after the resolution of your diabetic ketoacidosis. So this is the beta-hydroxybutyrate rises early and clears faster with decay resolution, and it is more sensitive and specific for the diagnosis of decay. Now, where should I manage the child of decay? So decay the child should be managed in a unit where you have the facility of infusion pump, you have ventilation and proper monitoring of the child. You should have well-trained nursing staff, 1:1 patient sister ratio. The staff who is trained in treating decay patient, who knows how to prime insulin, who knows how to keep the blood sugar, how to make IV fluids, and how to tailor the IV fluids. Your unit should have a proper written standard guidelines, which are to be followed. And then another important thing is you should have access to laboratory, because here is the one case, because in this condition you need a 4-hourly, 6-hourly electrolytes, arterial blood gas. So access to a good laboratory is mandatory. What are indications for PICU admission? We will electively shift these patients to PICU. One, a child with severe decay who has long duration of symptoms, the child who has poor peripheral perfusion, hypotension, compromised circulation basically, and depressed level of consciousness when you are suspecting cerebral edema. And those patients who are high risk for cerebral edema, especially age less than 5 years, severe acidosis, low PCO2 on admission, high blood urea nitrogen level. And if there are associated complications like AKI, cerebral edema, severe sepsis if you are suspecting ARDS. So all these children will admit to PICU. Now, once you have diagnosed, how will you treat the child? We should have some specific goals for the treatment. So our goals will be to correct the dehydration, to correct the acidosis, to revert the ketosis, to restore euglycemia. You are going to monitor the complications of decay and its treatment. You are going to identify and treat any precipitating event. And in known case of type 1 diabetes mellitus, you are going to find out what was the exact reason why the child ended up in decay. Prevention is better than cure. Now, for fluid is very important. Fluid and insulin, these two things are very important, where all the guidelines revolve around. So fluid therapy, so basic aims of fluid therapy are going to be, you have to restore the circulating volume. You are going to replace sodium and water deficits, and you have to improve the GFR and enhance clearance of glucose and ketones from the blood. Now, these are general points which you should remember whenever you are managing any child of decay. So these decay patients are dehydrated and potassium depleted, and they need more fluid and more potassium. Osmolar changes in the blood and brain have happened slowly. So there is formation of idiogenic osmoles, and hence they need to be corrected slowly. Now, fluid replacement brings down the sugar rapidly. What happens? You give a bolus. You are giving 10 ml per kg over 1 hour. So what will this fluid cause? This fluid will cause expansion of your intravascular volume. Along with that, it will enhance the renal clearance of the sugar, and it will improve the insulin sensitivity. So fluid replacement brings down your blood sugar rapidly even before you start the insulin level. And this we will discuss. Dehydration assessment is difficult due to preserved intravascular volume and loss of subcutaneous fat. So this was conventional dehydration assumption, which we have studied from the beginning. So mild decay has 5% dehydration, moderate has 7% dehydration, severe has 10% dehydration. So each percentage of dehydration is approximately 1% is 10 ml per kg. So the fluid deficit was approximately 50, 70, and 100 ml per kg. But now there are few changes. Yes. So this is a brief summary of few protocols which we routinely follow. Milwaukee 1988, BSPD 2020, and ISPAT 2018. Now it is ISPAT 2022. So which fluid you are going to give in the initial phase? So conventionally from years, the only fluid which is used for your fluid resuscitation as well as for your deficit correction is normal saline. So in all this protocol, the choice of initial fluid is normal saline. Milwaukee's protocol says you give 10 to 20 ml per kg over 1 hour. BSPD says here there is stratification. You have to classify whether the patient is in shock or whether the patient is not in shock. ISPAT says 20 ml per kg as soon as possible. Here the difference is between the duration. ISPAT says as soon as possible. Milwaukee says 20 ml per kg over 15 to 30 minutes. Then next was if the child is volume depleted but not in shock. So it is 10 ml per kg over 30 to 60 minutes in ISPAT protocols. Whereas in BSPD, it is 10 ml per kg over 60 minutes. So another important thing is that whenever you are calculating deficit replacement, you don't subtract bolus which you are going to the patients of shock. We are not going to subtract it from the deficit which we are going to calculate. Whereas in the ISPAT, there is no subtraction of the fluids, first half fluid you are giving. But in BSPD, you are going to subtract the fluid if the patient is not in shock. Maintenance fluid in all three cases, you are going to give by Holiday's agar formula. First 10 kg, you will give 100 ml per kg, 11 to 20 kg, you will give 50 ml per kg, and more than 20 kg, you will give 20 ml per kg. Now, deficit calculation is bit slightly different in all these three protocols. Milwaukee assumes 8.5% dehydration. Holidays, BSPD is same. There's the same. If it is severe, you give 10%. If it is moderate, you give 7%. If it is mild, you are going to give 5%. ISPAT says if it is mild, you give 5%. Moderate, you give 5 to 7%, not 7%. You can even give 5%. Severe, 7 to 10%. So that has to be optimized depending upon the patient. Another important difference is insulin. In both BSPD and ISPAT protocols, insulin has to be started 1 to 2 hours after your fluid resuscitation. Whereas in Milwaukee, you are going to start it simultaneously. And the starting dose of insulin is same 0.05 to 0.1 ml 1 unit per kg per hour. So this is a simple fluid calculation at 20 kg. A 6-year-old boy who is weighing 20 kg, pH 7.15. This means the child is in moderate decay, 7% dehydration as BSPD. He will receive 10 ml per kg bolus. That is 20 into 10 is 200 ml fluid over 60 minutes as a part of his initial fluid management. So your fluid orders have to be very proper. You are going to calculate deficit, then you are going to calculate maintenance, and then you are going to calculate total fluid volume which you are going to give. So deficit is 7% dehydration, 20 kg child. So 7 into 20 into 10. So that is 1400 ml. So if you divide it, and this deficit, all the deficits in ISPAT and Milwaukee, we replace it over 36 to 48 hours. So it is approximately 25 ml per hour. Maintenance cycle, if you calculate according to Holiday's agar formula, it is 62 ml per hour. Now here you can see we have, as the patient was not in shock, we have subtracted the bolus. So the total fluid per hour comes to be 25 ml per hour, deficit of 7% minus bolus over 48 hours plus 62 ml per hour of your maintenance fluid. So your total fluid has to be 87 ml per hour. Normal saline. We are discussing initial part only. This is another example. A 15-year-old child who is weighing 60 kg with pH 6.9, who was in shock at the presentation. She has received 30 ml per kg of 0.9% saline for resuscitation. These boluses are not subtracted from ongoing maintenance fluid as the patient is in shock. So basic concept is behind that is the child has more fluid requirements in cases of shock. So we don't subtract fluids, bolus amount. So 60 kg, 10% dehydration. So 60 into 10 into 10. So it is 6000 ml, which has to be replaced over 48 hours. So it is approximately 125 ml per hour, and maintenance is 96 ml per hour. So total fluid will be 125 plus 96 to 21 ml per hour. Here we have not subtracted bolus because the child was in shock. Now, these are the latest recommendations. What does ISPAT 2022 consensus guidelines say? If the child is volume depleted, but not in shock, you will give 10 to 20 ml per kg of 0.9% or normal saline, and it has to be infused over 20 to 30 minutes to restore peripheral circulation. If the child is in shock, 20 ml per kg 0.9% saline boluses should be given as quickly as possible, and you have to reassess the child after each bolus to assess the circulatory status, whether the child is improving or the child is not improving. If it is not improving, they will give additional bolus, and after 40 ml per kg, probably you'll think of starting inotropes. Now, conventionally, what we have learned these years and what we are doing is that normal saline is the fluid of choice. Ideal fluid in this situation is the fluid which will show a predictable and sustained response. as well as it should stay in circulation with minimum side effects. So hence, over the decades, we are studying normal saline is both for volume resuscitation as well as deficit replacement in cases of decay. But now the time is coming, there are new research articles to make us think, is this saline really normal? Now, this is simple comparison of the plasma electrolyte level and normal saline which we are giving. Now, here you can see plasma sodium is 135 to 145, and in normal 0.9% saline, it is 154, which is quite supraphysiological. Also, chloride is also very high. Chloride is 154. So, in adult studies, they have found that these high chloride levels will cause hyperchloremic acidosis. And this hyperchloremic acidosis is one of the triggering factor to worsen or cause acute kidney injury. How does it cause? It basically causes renal vasoconstriction. It will decrease the cortical perfusion. So nowadays there are raising concerns over whether this normal saline is really normal. Another thing is that this hyperchloremic acidosis will cause a persistent base deficit. You are using normal saline for a long time. It will cause hyperchloremic acidosis, which will cause persistent base deficit, and you will feel the child is not recovering from decay. So hyperchloremic acidosis and low bicarbonate level mask the decay resolution. It will unnecessarily prolong your stay of the patient in the PICU, as well as it will prolong the need of IV fluids and IV insulin. So they came up with balanced electrolyte solutions. So here we can see comparison between 0.9% saline versus plasmalite. Plasmalite, ORL, these are all balanced crystalloids. Now here you can see sodium is 140 in plasmalite versus 154 in normal saline. Significant difference in chloride you can see. Chloride is 154. Here chloride is 98. So this 0.9% you can cause hyperchloremic acidosis. And this plasmalite is our balanced crystalloid. They're basically protective. They will not cause hyperchloridemia. Okay. Another advantages are this plasmalite contains acetate anions like acetate and gluconate, which we find in the blood. They're physiologically similar to the body fluid, and it has mild alkalinization effects. But disadvantage of plasmalite, first major disadvantage, it is 5 times more costlier than normal saline. Second, it has potassium in it. It will worsen your hyperkalemia, and your lactates will get metabolized into glucose by gluconeogenesis, and it can aggravate the hyperglycemia. So what is best then? A normal saline or balanced crystalloid? So various fluid trials have been conducted. So there was one famous trial which is known as PINK trial, which was conducted in PGI Chandigarh in 2020, where they have compared saline versus plasmalite in children with decay. It was a double-blind randomized controlled trial. They have enrolled 66 children with decay, and they have grouped them into 2 groups, one receiving plasmalite and one receiving normal saline. And all children with cerebral edema, chronic liver disease, chronic kidney disease, which are confounding variables, are excluded from the study. And what they found in this study is that the incidence of new or progressive and acute kidney injury was similar in both groups, in the plasmalite as well as normal saline group, and as well as the time taking in the resolution for decay, need for renal replacement therapy, mortality was not that significant. So we have a lot of adult studies, but we still need more research for this. That balanced crystalloid should come into guidelines. Now, another important thing which we have discussed, which we are going to discuss, is calculation of fluid deficit. Now, as we have already discussed, there were studies who compared the accuracy of clinical based dehydration versus weight prior to the therapy and weight after the therapy. Now, these studies have found that clinical parameters as predicting for the severity of dehydration, they are inaccurate. They are inaccurate. There is risk of overestimation by approximately 3.2%. In addition, we have malnutrition still prevalent in India. So if you give a lot of fluids and lot of boluses, these children can have rapid fall in glucose levels and more electrolyte imbalance, which can add up to significant mortality and morbidity. So we are now coming up with new estimates for dehydration. Another thing which we have discussed, laboratory parameters are best, increased blood urea, nitrogen, and anion gap at presentation. They most strongly correlate with volume deficit. Useful to calculate corrected sodium concentration. Your sodium level will reflect whether there is excessive free water loss, whether there is water deficit, whether to increase the fluid or to decrease the fluid. So the basic thing is that refrain from subjective assessment of fluid deficits. Again, these fluids are double-edged swords. There are a lot of controversies, how much volume to give, what rate you should give, which fluid, whether you should give chloride restricted fluids like balanced crystalloid, whether if you give chloride liberal fluids like normal saline, it will cause acute kidney injury. Another, how much volume to give, whether you should go for fast rehydration or slow rehydration. Fast rehydration, overzealous use of IV fluids is one of the proposed mechanism for cerebral edema in children. So we need to optimize depending upon the patient, what fluid to give, how much fluid to give, depending upon the hemodynamic assessment. Now, this concept we are going to discuss. Do fluids determine the cerebral edema? As we already know, decay is this hyperglycemia is an hyperinflammatory state. Now, this hyperinflammatory state will cause increased permeability of blood-brain barrier. Now, suppose if you give fluid fast, if you do rapid hydration, if you give fast boluses, what will happen? This blood-brain barrier is already permeable. This fluid, there will be rapid osmotic shifts, and there are high chances of reperfusion injury, which can cause vasogenic edema. Now, we'll see this is two-hit model for cerebral edema. So in pathophysiology, acidosis, dehydration, hypocapnia. It will cause reduced cerebral blood flow, which will cause hypoperfusion and cytotoxic cerebral edema. This is what happens in pathophysiology of decay. Now, when you give fluids, what will happen? When you give fluids, there is reperfusion, and this reperfusion is going to increase going to leak. Already blood-brain barrier is leaky. It will precipitate your vasogenic cerebral edema. So the basic thing is neither too fast, neither too slow. You have to titrate fluids according to that. So after all this discussion, so current guidelines say कि modest correction considering the Indian status, malnutrition, precipitation of cerebral edema and all these things, they have given a modest correction of 6.5 to 8.5 is appropriate to avoid overhydration or underhydration. Fluids administered before referral should be subtracted. Fluid boluses used for resuscitation should not be subtracted. No boluses have to be subtracted from deficits. Now, this is what we are going to discuss: fast rehydration versus slow rehydration. So this was very famous study, Pediatric Emergency Care Applied Research Network, the Applied Research and Network. So this, the basic study of this study design was, this was a 13-center RCT assigned to 4 treatment groups. Groups were randomized, either the child will receive NS or half NS, and infusion is rapid or slow. And what they found at the end of the study was neither the rate of administration nor the chloride content of IV fluid significantly improved neurological outcome. But we need more research studies. Now we have learned how much bolus we are going to give if the child is volume depleted in shock, volume depleted not in shock. Now we'll see how you are going to replace the deficit. deficit replacement has to be slow, over 36 to 48 hours. Now, deficit fluid, you can give 0.45 to 0.9% normal saline with added potassium chloride, potassium phosphate, or potassium acetate. Whether to give 0.9%, whether to give 0.45%. Initial 4 to 6 hour isotonicity is important, because we can't give hypotonic fluids in the first 4 to 6 hours, because that will cause rapid osmotic shift. So isotonic or hypotonic, whether later in the deficit part, it will be based on the hydration status of the child, serum sodium concentration, and osmolarity. And the estimated fluid deficits are to be replaced over 48 hours. Most cases typically of decay typically resolve within 24 hours. Another thing is that urinary losses are not to be routinely added in the replacement, because these children are polyuric and initially they will have more diuresis, urine output will increase. So you are not going to routinely add these urinary losses in your replacement unless and until it is a mixed presentation of decay and hyperosmolar syndrome. Now, what is the role of sodium monitoring of sodium levels in decay management? So what happens is that initially children will have a dilutional hyponatremia. You have hyperglycemia, you have osmotic drop of water along with it. This will cause hyperdilutional hyponatremia. So once you start treating the decay, the glucose concentration will start declining. Sodium concentration goes on increasing. So previously it was said that high sodium content can rapidly correct acidosis, and this high sodium, increasing sodium level, you have to monitor the rates. Increasing sodium levels are actually protective against cerebral edema. These were previous study, but what after the PECAN study, ISPAD guidelines say promoting rise in serum sodium concentration should not be a routine focus. You should not be just you monitor electrolytes level, whether and then you decide whether to increase the rate or decrease the rate. So this is one of the very good article which I recommend everyone should read, which will provide new insights in the fluid therapy. Best written by Dr. Jayashree Muralidharan. She is pediatric intensivist in PGI Chandigarh. Fluid therapy for I have taken references from this article only. Now, once you have optimized the fluid, you are going to start insulin therapy. Usually, you are going to start insulin is started 1 to 2 hours after the initial volume expansion. It should not be given as IV bolus, because IV bolus increases the risk of cerebral edema. Another important practical thing, which when we are preparing insulin, is that priming of the tubing is very essential. You use a 50 ml syringe, you take 50 ml normal saline, you mix 50 units of regular insulin in it, and 20 ml of the priming of the tube is essential, because insulin has the tendency to get adsorbed to the PVC tubings. So your insulin delivery will not be proper if you are not going to prime the tube. Then you, after dilution, then will start at 0.05 to 0.1 unit per kg per hour. And in children who are already on long-acting insulin, you can continue long-acting insulin along with IV insulins. And for children on continuous subcutaneous insulin infusion, you have to discontinue that prior to you are going to start IV infusions. Now, this is one study which shows the importance of priming versus no priming. Now, here you can see, if you have not primed at the flow rate of 0.05 ml per hour, insulin, if you see from unprimed PVC tubing at 1, 2, and 4 hours is pretty very less, 17%, 11%, 27%. And later on, as the fluid passes, it becomes 55% at the end of 8 hours. And 100% at 24 hours. And where advantage of priming, that when you prime the tube, it is 70% at 1 hour insulin recovery from the tube versus 17% at 1 hour if you don't prime. So priming of the tubing is very important. Then what dose of insulin you should use, 0.05 or 0.1? So there was one RCT conducted by Karthi et al. 50 consecutive children with age less than 20 years into low dose 0.05 versus standard dose insulin. So they have found that low dose insulin was non-inferior to standard dose with respect to blood glucose decrease or resolution of acidosis. So you can start with 0.05 and then you can increase to 0.1 unit per kg per hour, depending upon the response. So dose of insulin is 0.05 to 0.1 unit per kg per hour by IV. If blood glucose is less than 250 or fall in blood glucose is more than 100 milligram per deciliter per hour, you are going to add 5% dextrose. And if blood glucose is less than 100, then you are going to change to 10 or 12.5% dextrose. Never ever stop insulin. Insulin has never to be stopped. You can decrease your insulin rates to 0.03 to 0.05 unit per kg per hour. And what are your endpoints of this insulin infusion? Endpoints of insulin infusion in cases of DK, when we are going to stop this IV, when your pH is more than 7.3, your bicarb is more than 18, and your blood ketones are less than 1 millimoles. You are not going to measure urinary ketones. Urinary ketones have no role in deciding termination of insulin infusion. Enough. In mild cases, ISPAT says yes, you can manage in HDU or ward if your sister is trained with subcutaneous insulin. If the child is accepting orally and there is no vomiting. So in India, they say in uncomplicated mild to moderate DK, early or too early subcutaneous rapid-acting insulin analog like Lispro or Aspart is as effective as IV regular insulin. And then depending upon blood sugar, you will titrate the dose. For regular insulin, it is 0.13 to 0.7 unit per kg per dose every 4 hourly. So short-acting insulin is 2 hourly, regular-acting insulin is 4 hourly, and then 10 to 20% increase or decrease in the dose, depending upon the blood glucose level prior to your next insulin injections. So these are various fluid trials for DK. You can go through it. Burns Pink trials, RTD trials, SMART studies. So all have focus on high chloride levels, incidence of AKI, precipitation of cerebral edema. Now, another important thing in DK is replacement of electrolytes. First important electrolyte is potassium. Patients are going to be potassium depleted right at the outset. Right at the outset, they will have potassium deficiencies, even though your potassium levels are normal. So why they are potassium depleted? One is the hypertonicity and acidosis will cause potassium efflux from the cells. Osmotic diuresis, as we discussed, will cause loss of potassium. There is dehydration, there is volume depression. This will cause secondary hyperaldosteronism, which will further increase the urinary loss of potassium. So initial serum potassium may be normal or increase, but it is always depleted intracellularly. So once you start insulin therapy, your renal perfusion is optimized, acidosis is corrected, potassium can fall precipitously. This is very important because this is one of the electrolyte imbalance which can cause sudden death if you don't treat. So when do you start potassium? If the child is hypokalemic, if potassium levels are low, just immediately when the child has arrived in here, you will just start potassium with your first fluid bolus. With how much potassium? 40 millimoles per liter or 20 millimoles in 500 ml. If the child has normal potassium, here you can wait for 1 hour and then you can start along with your insulin. But if the child is hyperkalemic, you are not going to give potassium until your urine output is documented. We'll keep on repeating potassium one early, and once potassium is less than 5.5, then you will add potassium in the drip. So starting concentration is 40 millimoles per liter. If the child is having hypokalemic, you are getting rhythm changes, you can give potassium bolus 0.5 ml per 0.5 milliequivalents per kg per hour. If hypokalemia persists despite a maximum rate of potassium replacement, then your rate of insulin has to be reduced. Recheck potassium every 1 to 2 hours if potassium values are outside your normal range. Another electrolyte which is lost in urine is phosphate. We don't usually replenish phosphate. Osmotic diuresis causes phosphate loss in DK, which is further exacerbated by insulin therapy. It is mainly because of your reduced 2,3 ATP and 3 BPG level. Hypophosphatemia we routinely don't correct unless it is level less than 1 milligram per deciliter. Bicarbonate therapy. No role of bicarbonate. Absolutely no role of bicarbonate in treatment of decay. There are only two valid indications for giving bicarbonate. One is life-threatening hyperkalemia. Second is when you have a pH of less than 6.9 with obvious decreased documented cardiac function. Then only you are going to give bicarbonate. Because this bicarbonate therapy, rather than improving, it will cause more harm because it causes paradoxical CNS acidosis and hypokalemia. And it is one of the factors which is implicated in the development of cerebral edema. So there are only two indications. If at all it is indicated, it is 1 to 2 millimoles per kg, which is given over 60 minutes. Monitoring, very important. You are just treating the child, you are not monitoring, not justified. You have to monitor the child. So there is clinical monitoring, there is treatment related monitoring, and there is laboratory monitoring. Clinical monitoring, early you are going to check vitals, heart rate, respiratory rate, blood pressure, hydration status, urine output. Very important, Glasgow Coma Scale, bilateral pupillary size and response. Because here you can pick up early cerebral edema. This is very important. Monitoring for GCS and bilateral pupillary size and response. And treatment related, early, how much is input, how much is amount, how much insulin you are giving, whether you are increasing, you are decreasing, what are the blood sugar levels, you are going to titrate according to that. Early monitoring of blood glucose level. CGMS, continuous glucose monitoring system, is a recent technique where it measures interstitial real time. It will provide a real time monitoring of interstitial blood glucose, which helps in minimizing your pricks. You don't need to prick the child every hourly. Again, for early venous blood glucose, serum electrolytes, blood urea nitrogen, calcium, and hematocrit. We did not take to repeat this, as we all know. This is monitoring sheet, which we follow in our unit, where you can see all the things which we have discussed are included. Now we have optimized the fluids, we have started insulin, but still after 6 to 8 hours, you are not seeing improvement. What you are going to check? First thing, whether your fluid orders are proper, whether you have optimized your fluid orders, whether fluid resuscitation is proper. Check your fluid orders again. Second, are fluids going properly? You have put one order, the sister is giving some another IV fluid. So check what fluid is going on. Third, insulin. Whether priming was done, whether insulin pump is working properly, whether insulin is going properly, and other things which you should keep in the back of mind is renal failure, underlying sepsis, and hyperchloremic acidosis. Since we tend to give a lot of normal saline. So this we have already discussed. When we are going to stop the IV infusion, pH more than 7.3, bicarb more than 18, blood ketones less than 1. You will give subcutaneous insulin 60 minutes before stopping the insulin infusion for short-acting insulin, and 30 minutes after rapid-acting for rapid-acting analogs. If you are planning to start basal insulin, it should be given 12 hours prior. And you have to monitor the blood glucose. So complications of therapy, we already discussed. One is cerebral edema. Your overzealous fluid administration, undertreated, both can cause cerebral edema. Infections, it is already an immunocompromised state, so they have chances of infection. Hypoglycemia, are going IV insulin. This has to be avoided. Hypokalemia and hyperchloremic metabolic acidosis. Yes, a child of decay can die. So what are the usual causes of death in a child of decay? One, cerebral edema. Second is aspiration. Third is hypokalemia. Fourth is inadequate resuscitation. Important point to stress in that is all are avoidable. All are avoidable. If you monitor properly, if you optimize fluids, electrolytes, everything properly, these things can be avoided. Now we'll discuss complications a bit fast. Cerebral edema. Cerebral edema is accounts for 60 to 85% of all diabetic deaths. overall cerebral edema occurs in 1% of all DKA cases, and the peak incidence of cerebral edema is between 4 to 12 hours of your initiation of the treatment, because here is a time where your fluids and electrolytes will have osmotic shifts. Now, what are the risk factors for cerebral edema? Age less than 5 years, new onset diabetes mellitus, long duration of symptoms, severe hypocapnia, increased blood urea nitrogen at presentation. These are intrinsic risk factors right at the onset. Treatment related bicarb correction, we said we are not going to give bicarb. Early decrease in serum effective osmolality. So here is the point where we tend to avoid overzealous fluid administration. And attenuated rise in serum sodium concentrations are low. And large boluses given within the first 4 hours. And in the administration of insulin in the first hour of the treatment, this is another risk factor for precipitation of cerebral edema. So early warning signs, you have a child, the child suddenly develops headache or recurrence of vomiting, there is change in neurological status, or you get new neurological deficits like you have new onset cranial nerve palsies, abnormal pupillary responses. Then you have Cushing stride, rising blood pressure, bradycardia, irregular respiration, and rapidly rising sodium concentration. So you have to monitor the child. So this is the diagnostic criteria for cerebral edema to major one minor is required. How do you treat cerebral edema? First, early suspicion. Second, as soon as you suspect the child is predicted to have cerebral edema, elevate the head of the bed to 30 degrees. Check your fluid orders again. Don't try to give over fluids. You optimize the fluid just to maintain the blood pressure in normal levels. Don't give much, don't give less. Just maintain the blood pressure so as to maintain the cerebral perfusion pressure. Avoid hypo or hypertension. Mannitol, hypertonic salines, osmotherapies you have. Generally, intensivists prefer hypertonic saline, but you can also give mannitol. There is no such evidence that hypertonic saline is superior to mannitol. Mannitol will increase your osmotic diuresis. Dose of mannitol is 0.5 to 1 gram per kg in 15 minutes and repeat if there is no initial response in 30 minutes to 2 hours. Alternately, have 3% saline in a bolus dose of 5 ml per kg over 15 minutes. So generally, if you have done with your first shot of mannitol, you can go with, instead of giving second shot of mannitol, you can go with hypertonic saline. They can have an additive benefit. Intubation may be necessary if the child develops abnormal breathing pattern. And once you have stabilized the child, then you can plan for neuroimaging to rule out intracranial hemorrhage or underlying cerebrovascular thrombosis. Now, these children are prone for infection. It could be bacterial, fungal. Recently, there was rise in mucormycosis, especially during COVID situation. Diabetic patients had a lot of mucormycosis. So they have predictors, indicators are persistent fever, leukocytosis. You can, in case of mucormycosis, you can have black nasal discharge. They are prone for pulmonary invasive infections like pulmonary aspergillosis. So basically, depending upon the focus of infection, you're going to plan your antibiotics. Yes, this is another important thing. AKI, renal replacement, AKI or renal failure. Now, development of renal failure during management of decay is omnious sign as it adds to your cerebral edema and ARDS. It predisposes to that. Now, usually it is very difficult to diagnose AKI in this child because urine output is usually preserved. 0.5 ml per kg per hour will occur in the end stage. It is very difficult to recognize the AKI. So, rifle staging, P rifle staging, depending upon estimated clearance, creatinine in clearance. Few studies have stated that rifle staging have more predictive value for determining AKI in these children. Again, it is just rifle is risk injury, failure, life loss, and end stage renal disease. Risk is when your estimated creatinine clearance is less than decreases by 25%, injury is 25 to 50%, and failure is more than 75% or your expected creatinine clearance less than 35. So you have to keep monitoring that. Early consideration for health. So once the child sets up in AK, you require a tight control of fluid, electrolytes, and your osmolality. Early consideration of hemodialysis is required in these settings because of the difficulties in fluid and electrolyte management. You will start for renal replacement therapy when your medical measures fails. There is persistent anuria, any persistent anuria, dyselectrolytemia, metabolic acidosis with high inotropic requirement. What RIT options we have? First, PD. PD is less costly, but the disadvantage is that the solute clearance in decay is unpredictable in peritoneal dialysis. Also, it is difficult to titrate, and there are high chances of PD catheter infections. So, preferred modality for RRT is CRRT, continuous renal replacement therapy, even not intermittent hemodialysis. This we have discussed. Hyperchloremic metabolic acidosis. It usually observed after 8 to 12 hours of therapy. It is due to their excessive chloride administration. And how do you suspect? It is suspected in the presence of persistent metabolic acidosis. You have a persistent base deficit with normal blood ketone levels. Nothing much is required to treat this condition. It should be managed. Just you change the fluid with 2RL or lower chloride content. Nothing aggressive to be done. This is somewhat for how do you diagnose this hyperchloremic acidosis? It is by delta anion gap or delta ratio. Delta anion gap is simply anion gap minus 12 plus bicarb. If it is less than 18, then you suspect additional normal anion gap metabolic acidosis. Just treating decay is not important. Prevention is also important. And this is the, so we have primary, secondary, and tertiary level prevention. Primary prevention, high societal or community index for the suspicion of type 1 diabetes mellitus. Previously, there was studies where they have campaigns for the screening of diabetes children. Simple, there was one study where they have screened urine sugar of every sick child. You do urine screening of every sick child. So that can prevent the child landing up in severe decay. Continuous glucose monitoring systems in a child with already diagnosed type 1 diabetes mellitus, frequent blood glucose monitoring during sick days, very important. Close blood glucose monitoring and rapid correction of hyperglycemia for patients on insulin pump. Secondary prevention, early diagnosis, blood ketone levels. This is point of care in all children. Home blood ketone or urine ketone monitoring during sick days, careful fluid and insulin management, and tertiary prevention is early identification and treatment of cerebral edema, appropriate treatment of infections. So these are just recently released IPP National Treatment Guidelines 2024 for diabetic ketoacidosis. The diagnostic criteria is same. Once you have as a severity staging is also the same. Once you have assessed the severity, if the child is having mild decay, the child is having normal sensorium, tolerating oral fluids, will start with oral rehydration, subcutaneous insulin, which we have already discussed, no fluid bolus is required. And if it doesn't improve after year 4 to 6 hours, then you will treat as per moderate or severe acidosis protocol. If the child is having moderate or severe acidosis, the child is kept NBM. Fluid, the initial fluid of the choice is still NS or balanced crystalline solutions. Again, here they have corrected the deficits. It is not 5, 10, 15. It is now 6.5 correction for mild to moderate and 8.5% correction for severe. And deficit has to be corrected over 36 to 48 hours. And you start with 5% dextrose. If RBS is less than 250, add potassium after documenting urine output. Then you are going to monitor. So the ongoing monitoring is continuous throughout the entire phase. You are going to continue with your cardiac monitoring, fluid monitoring, neurological monitoring, everything. So after, if there is, after 4 to 6 hours, if there is improvement, then you will start with half DNS if RBS is less than 250 with ongoing monitoring. And once the child meets endpoints of decay, then you will transit to subcutaneous insulin and start the pills. If there is no improvement, if the 4 to 6 hours, first check the patency of IV cannula, check the expiry date of insulin, how insulin is prepared, how it is diluted, then rule out any uncorrected dehydration, topical sepsis, lines are flushed properly, And if you can increase the dose up to 0.5 per kg per hour. Same neurological deterioration, you have to secure if the child is having worsening of the sensorium, new onset cranial nerve palsy, bradycardia, hypertension, as we have discussed. The treatment is same. You will secure the airway, head and elevation, adaptive physiological ventilation, reduce fluid rate by 1/3, normal saline or mannitol bolus, maintain the cerebral perfusion pressure, and once the child is stable, you do neuroimaging. Thank you.
Thank you, Mohin sir, for a wonderful and in-depth discussion about diabetic ketoacidosis. So why we selected this topic was because almost, as you told, 15 to 70% of patients with new onset diabetes, diabetes patient present as a diabetic ketoacidosis. And here I want to say that diagnosis is very important. If the child is having tachypnea and there is no respiratory distress, no signs of infections are there, you just suspect there is some metabolic cause. You can do baseline BSL, and then you can do urine examination that can be done at your as a common pediatrician. It can be done at common pediatrician level. So as Bhutra sir already told, this is one of the conditions which when treated, diagnosed early and treated with protocol, it has given good, fairly good result when treated early. So I would like to ask Bhutra sir to give their expert comments.
Well, this was a very, very elaborate presentation by Dr. Moin, and I listened to entire presentation with great interest. He has discussed in depth about the epidemiology, history, various protocols which are available, and the recent most protocol which is published by ISPAD in 2022 and thereafter by Indian Academy of Pediatrics in 2024. So, what changes that's important that we must um, look at when we were managing a couple of decades back, this decay, and now, few things that I would like to make a comment. First thing, should be managing decay at an appropriate center with a multidisciplinary team that he has rightly pointed out. So if you do not have an enough infrastructure, enough manpower, and the team, which includes a pediatric endocrinologist, pediatric intensivist, and a good nurses lab backup, then you should try make an arrangement after stabilizing this child to shift to a better care, especially those who are having moderate to severe decay. Of course, identification is very important, and which he has rightly said in all guidelines which are available. Of this, rather than doing a urine ketones, blood ketones, so having a blood ketone meter, because that's important. Not every unit has blood ketone meter, just like you have glucometer. So you need to have a blood ketone meter bedside available with you, because this is a beta hydroxybutyric acid which will rise early, and the other ketone acids like acetoacetic acid, they are going to take some time to come in urine. Also, they will take time to clear out. So your judgment cannot be that accurate based on urine ketones. Of course, they are easily available. So if something like blood ketone meter is not available, then only go for a urine ketone uh, analysis. Thereafter, uh, we started giving fluids, and still there are a lot of confusions, which fluid to give, how to give. So there are various protocols. What is important is to follow one protocol, the recent most, stick it and stick to that protocol, and take help of someone who is an expert in managing decay as a backup, because though most of the time it will have wonderful effects, there will be time that it can cause problems like cerebral edema, then persistent metabolic acidosis, hypertension. Someone just also mentioned in the chat box that what to do with hypertension,
Yeah.
persistent bradycardia, and these are the problems which can even lead to death or brainstem dysfunction because of the cerebral edema. So to pick up that early and manage them accordingly is of utmost importance. So the change that we found that NS or balanced salt solution, they are almost working similarly. Rather than giving fluid bolus, you should be going slow unless and until the patient is in shock. So go slow over 30 to 60 minutes and subtract this fluid from the fluid calculator. Previously, we used to calculate over 24 hours. Now we calculate over 48 hours. So being gradual is of great importance so as to minimize the osmolar change in the blood as well as the brain. So this is again a key. Priming the infusion pump or the syringe pump with insulin is another key message that he has given, because this we fail and it's a nursing job, but we must ensure that they have done this. So once you prepare an insulin, so you flush that, prime your tubing with the insulin fluids. And previously we used to start simultaneously fluid and insulin. Now, as per the recent protocols, we start with fluids. With that only, the blood sugar will come down to some extent, and then we start insulin. Again, starting insulin at slightly lower dose of 0.05 unit per kg compared to 0.1 unit per kg, it was not inferior. But I'm sure practically people have found that there were less number of hypoglycemic episodes with 0.05 unit per kg per hour compared to 0.1 unit per kg per hour, especially in the kids who are younger and malnourished. So that is again an important message that he has given. Protocolized monitoring is important. One more thing that can be added here, which most of the protocols are not giving right now, but most intensivists do follow. So rather than blindly giving the fluids, we can titrate the fluids by the use of ultrasound. So you can do bedside ultrasound, you can do bedside echo and assess the fluid levels. And accordingly you go, rather than blindly giving 20 ml per kg fluid boluses or 10 to 20 ml per kg of the rapid rehydration. So go slow, use infusion pumps unless until the patient is in shock. And if you are giving 10 ml per kg, reassess the perfusion. And it's important to measure the blood gas, bedside, lactates. So all these markers, they are again going to be important in managing these kids and titrating the fluids. That's another thing. Then short-acting insulin, regular insulin, long-acting insulins. We should have a thorough knowledge of all this and which insulin is being given. If the child is already a known case of type 1 diabetes mellitus, which type of insulin it is. So an important message again he has given that if you have mild diabetic ketoacidosis, so previously all mild DK also used to get admitted and to be put in ICU, and they were started on basically IV intravenous insulin infusion. So these are, they are selected cases, and if you have a good unit with good monitoring facilities, the mild DK can be managed with subcut insulin and good oral rehydration, or maybe IV rehydration with subcut insulin. So this is already being followed for last 4-5 years in most of the units now. And you can obviously switch the protocol if it's going towards moderate to severe. But then that is an important key change that he has mentioned. There is an important message about persistent metabolic acidosis. So he has pointed out all the facts related to patients, related to your therapy, the infusion rates, the pump failure. One more important condition which we have faced not more than one time, it was an existing renal tubular acidosis with diabetic ketoacidosis. So if you have persistent metabolic acidosis, especially with calculation, you find a normal anion gap metabolic acidosis along with high anion gap metabolic acidosis, you should consider apart from hyperchloremic metabolic acidosis, is another condition that is renal tubular acidosis. So if a child with failure to thrive, with recent onset diabetic ketoacidosis is failing to improve the way it should be, and there is a persistent metabolic acidosis, especially the pH is less than 7.1, then this is one situation we should rule out. And this is one condition where the infusion of soda bicarb can be helpful. as you rightly pointed out, sodium bicarbonate therapy infusion, which many used to give earlier, maybe a couple of decades back, this is by rule, it's not required. With good hydration and insulin therapy, the acidosis usually improves, and it's basically detrimental to give soda bicarb. Picking up cerebral edema at the right time is crux and managing it accordingly, along with electrolyte disturbances like hypokalemia. Hypophosphatemia is very rare, but then if you see severe energy failure, as you pointed out, this is rarely you may require to give potassium phosphate supplementation. So a very well presented protocol in pediatric DK. I must congratulate Dr. Moin and the team Maharashtra IP for uh, having such wonderful.
Yeah. Sir, actually, this is the crux of idea. Dr. Ram Gopal sir's and Bhavesh Mithya sir's main crux of idea is to study all the protocols. You give comparison of all the protocols and give the recent one and give clear-cut guidelines to our pediatricians who is common pediatrician practicing at rural area everywhere. This is the whole idea behind this presidential action plan, this protocol on pediatric practice, that we should come up with clear-cut guidelines after studying all the protocols. And I think he has given good justice to this topic, and he has given in detail all the discussion is good. I want to just ask some questions asked by the audience before concluding. So first, the question is diabetic ketoacidosis with persistent hypertension. Single word answer, sir, for them.
Yeah, so the persistent hypertension in DK is pretty common. Should try and look for any associated or development of cerebral edema, especially if there is a Cushing's triad with bradycardia. This is one situation we should be ruling out.
Yeah. Sir, second thing, use of analog insulin during decay.
So, if it is already diagnosed case of diabetes mellitus, as already it was well elaborated by Dr. Moin, the one which we are using should be continued. But for the moderate to severe decay, especially severe decay, go for the IV infusion, for which we are using right now regular insulin only.
Yeah. And one question is role of thyroid function test. This is asked by audience.
Yeah. So a few conditions which commonly exist with the diabetes, type 1 diabetes especially, like other autoimmune conditions, other endocrine disorders. So as a protocol, we do check thyroid functions whenever there's a newly diagnosed diabetes. Another thing is the celiac disease that we do check, and we prove the insulin deficiency by going for a C-peptide levels for a newly diagnosed diabetes.
Yeah. And the another question is urine ketone remains positive, that you have given the answer, sir, because urine ketone remains positive for a few days.
Yes.
I would like to, sir, with due permission of President and Sir and Secretary General, can we conclude the session?
Yes, Kundan.
Sir, you want to comment anything, sir, regarding this?
Already we had more than 250 delegates, and still around 200 people are listening. So that shows the success of the program.
Yes, sir. Yes, sir. Sir, I would like to give vote of thanks. I would like to Dr. Ram Gopal sir for this wonderful concept of protocols in pediatrics in the presidential action plan. Dr. Amol Pawar sir for consistent support and presence. And I would like to thanks expert Dr. Anand Bhutra sir for being there, being attentive, answer every questions and given expert comments. I would like to thanks MMC Observer. Today we are getting MMC Observer, Dr. Sanjay Gosavi sir, a senior pediatrician from Nashik. I will also like to thank Dr. Matin Sheikh and my all EB members who are doing this wonderful job of every work they are doing together. Then I will most sincerely I like to thank Dr. Speaker Moinuddin Tamboi sir. He has given in depth detailed discussion and covered all the topics and given current guidelines, so that I can now say that every pediatrician is able to treat the DKA, and what to do and what not to do he has understood very well. And most importantly, I would like to thank all the delegates, those delegates who are there, as Ram sir already told, almost more than 260 were there on Zoom and live YouTube. There are more delegates were there, and they were remained till end, and they were actively involved and asking questions also. And also I would like to thanks DIP platform, Dr. Vishal sir, Mrs. Pallavi ma'am, for their constant support. Thank you. Sir, can we conclude the meeting?
Yeah, and now 17 we are having Wednesday wisdom. That
Yeah.
would be the topics would be headache in the children. And
also-
18th would be the learning from the lesion, and Dr. Uma Ali madam would be the lesion. She would be addressing on the nephrology. So I request everyone to join on 17 and 18.
Yeah, and I'll also like to ask delegates whatever protocols they want to discuss. You can give suggestion to us. We are covering most of the common protocols, common topics. It is not necessary, as Ram Gopal sir has already told you, it is not necessarily related to PSU only. We can discuss the common topics, the protocols on that topic in depth, and give guidelines on this platform. So any suggestion from our members are most welcome, so that it will be benefited to all the pediatricians. Thank you.